Hi everyone, welcome to researchmd.com. We got a great topic today again. Today we're going to teach you all about steroid induced myopathy. Okay, again, my name is Pramil Cheriyath. I am a physician. I work as a director of research. I'm a program director, internal medicine residency program director for transitional residency program, also assistant professor of medicine, Hackensack School of Medicine. And so let's get into our subject and start talking. So now steroid, if you look at steroid, now there is, everybody every physician or clinician have a tendency to give steroids without necessity, and sometimes in needed we also give it, right? So it's important to find out what are the complications the steroids can cause in this. One of the main complications we need to worry about is steroid-induced myopathy. It was first described by Henry Cushing in 1930. Few characteristics: a non-inflammatory myopathy. That means it's a painless, okay? Inflammatory is usually painful, right? And it causes proximal muscle weakness and reported anywhere 2 to 21% receiving corticosteroids, okay? So next slide, we just have to kind of look at the classification of steroids. Very important to know. There's anabolic steroids. If we talk about the athletes trying to muscle build up, what do they abuse? Anabolic steroids. We're not talking about that. We're today talking about glucocorticoids, mineralocorticosteroids, and those are the main things we're going to talk about it today, okay? Now, let's go to the next slide. If you look at it, corticosteroids, you got main thing, we have glucocorticosteroid and mineralocorticosteroids. Okay, glucocorticosteroids, you have short-acting, which is cortisol and cortisone, and you got intermediate acting, which is kind of 12 to 36 hours. Good to know the hours they work in: prednisolone, and methylprednisolone, and triamcinolone, okay? And then you have long-acting, which is dexamethasone. We know like a lot of COVID patients now getting it now. And then paramethasone and betamethasone. Betamethasone we usually, in the pregnancy patient, we always give, right, to prevent like preterm labor. And when you look at the other side, mineralocorticosteroid, you got aldosterone, you got DOCA, deoxycorticosterone, and fludrocortisone. Okay, those are the things we have to know about it. So there's something also called a fluorinated versus non-fluorinated. Just look at that also. Fluorinated, you got triamcinolone and paramethasone, you got betamethasone and dexamethasone are fluorinated. The other compound non-fluorinated like cortisone, hydrocortisone, prednisolone, methylprednisolone, non-fluorinated. Okay, we will come back. Why did we have this differentiation kind of later on? When you look at it, it's very important to understand the pathophysiology. How does it steroid causes like the myopathy, okay? So there are two important mechanisms. One is muscle proteolysis, and the other one is inhibition of the protein synthesis. When you look at the muscle proteolysis, three major systems: ubiquitin proteasome system, lysosomal system, and calcium dependent system. We'll come back to the next slide. And the other part, you have the inhibition of the muscle, like inhibition of transport of amino acid, right? Inhibit the insulin, IGF-1, and then inhibit myogenesis also. So we have another diagram over here. Let's look at the first one, steroid. How does it cause the direct catabolic effect? That's protein breakdown, okay? It's just like, I think we talk about the ubiquitin proteasome system, and then you got the lysosomal system, and then you got the calcium dependent system. They all kind of degrade the proteins. And one particular, if you check their urine, you can have urinary 3-methylhistidine excretion in the urine, you can see. Now the other part, the steroids also, what do? Like it decrease the protein synthesis. We already talked about transporting of the amino acid which is needed for protein. They inhibit that. And inhibition of insulin, IGF-1, leucine is another amino acid. It inhibits of the myogenes also, which is involved in the transcription of and differentiation of the satellite cells into muscle cell, right? Satellite cell, when you talk about satellite cell, this is the precursor cell for the muscle cells. And then also steroid causes is a local effect, right? And by the stimulate the production of myocytic cells, the skeletal cells, and all that. Affect growth factors also. Okay. So all these are the three pathophysiological mechanisms. But always remember, you got the direct catabolic effect, which is the proteins are breaking down, and the steroids are called decreased protein synthesis, like decreased production. And then you have the local effect, inhibiting the protein synthesis by some of the growth factors also. Okay. Now, who are the patients usually risk for, right? Is everybody going to develop steroid-induced myopathy? No, only the few people, right? Which people are at risk? Age, if they're increased age, like every disease, if the increased age is important, right? They are female, more susceptible. If they have multiple medications like polypharmacy, if they have like substance abuse problem, and if they own like a mechanical ventilator and then you're using curare, like vercuronium or the neuromuscular blockade, they also have very high risk. If they got cancer, they also have very high risk. Prednisone 30 milligram per day, high risk. If they're using fluorinated steroid, that's why we were talked about before, like fluorinated and non-fluorinated, okay? If they're using fluorinated compound, there's an increased risk, right? Now, clinical presentation is also a little bit important, okay? So the most of the patient, can have like an acute and a chronic presentation, but always think about chronic. Acute is kind of rare. When does it acute happens? It's like usually you start on heavy dose of steroids. Where do we do that? A patient in the ICU, maybe septic shock or something, or like, you're starting heavy dose of IV steroid, they can develop. They're a little bit different, the presentation. They could be rapidly progressive, proximal muscle weakness. Sometimes it may be painful, but in this case, CK, creatine kinase, is going to be elevated, okay? So remember that. When you come to chronic, it's gradual process. Usually happen after like 4 weeks of presentation. Progress slowly. There's going to be like a muscle atrophy, and again, we talk about proximal muscles, okay? And in the chronic, that is usually normal. So if you have to remember, always remember chronic. Nobody's going to ask about the acute presentation that much, but acute can also happen. That's why I just kind of put it over there. Most likely, this is going to be a chronic situation. So what are the clinical presentations? Remember the 5 P's. P, painless. P, proximal muscle weakness. P, pelvic girdle muscles are affected. P, physically inactive people more affected. And proportional, they're symmetrical weakness. Okay, the 5 P's of clinical presentation. Remember that. And then when you look at the neuroexam, cranial nerve examination is going to be normal. Muscle reflexes are going to be normal, okay? So always remember, what are the proximal muscle weakness? What does it do? Like if you ask somebody to get up from the chair, it's very hard for them to get up because they have to use the proximal muscle. Unable to climb stairs, also a sign of proximal muscle, right? Inability to brush the hair, proximal muscle weakness. So if you have to take something out of the slide, patient usually they cannot get up from the chair, okay? They're unable to climb stairs also because of the pelvic muscles. The time course we talk about, if it is acute, it can happen like in a week, but most of the time we're going to forget about acute. We're going to concentrate on chronic, right? Usually 4 weeks after, but again, acute can happen a week after high dose IV steroid, especially in the ICU, right? Lab findings, a little bit importance up here. It's CK is not elevated. Remember that. Always remember, CK is going to be normal. All the muscle breakdown enzymes like LDH, aldolase, CK, everything's going to be normal, okay? What are the things going to be abnormal? Urine creatinine is going to be increased. Remember that. Hypokalemia. Those are the other 2 findings. If you have urine creatinine is going to be increased and hypokalemia, okay? But the other creatine kinase is going to be normal. Now, if you look at it, it usually there's 2 types of fibers, like when you talk about the muscle fibers, right? Actually, you can say 3, there are 3 types. So in this, atrophy of type 2 fibers, that is the most important. That's what you always kind of remember that. Type 2B fibers are the one affected in this pathophysiology. EMG is going to be normal. So if you have if you're taking a test, always remember EMG is going to be normal. Nerve conduction studies, they're going to be normal because it's not nerve, it's muscle, right? So nerve conduction study is normal. If in an examination they can throw you curveballs, kind of putting the nerve conduction and EMG. So always EMG is going to be normal, nerve conduction is going to be normal. Treatment, how do you treat this? Cessational reduction, or you stop the steroid, okay? And then sometimes it takes like 2, 3, 4 weeks or like 2 to 3 months to get the complete strength back. alternate day regimen. If you do like a daily steroid, convert it into maybe every other day, or decrease the dose, switch to non-fluorinated. Remember in the previous slide we used to talk about the fluorinated versus non-fluorinated compounds, right? And always make sure nutrition, right, is very, very important, because you need protein. It's already, protein is like messed up. They're breaking down, not synthesis. Imagine if they are like, there is no protein in the body. Make sure there is enough nutrition in the body, okay? Thank you very much for joining us today, and please subscribe to our channel so we can make great presentation like this again. Thank you again.